Dr. Lesley Manson has spent nearly 2 decades providing direct service. Her dedication to behavioral health and integrated care models led her to directing behavioral health programs, providing continuing education to healthcare professionals, and developing workshops and trainings for behavioral health and primary care providers to be successful and integral members of healthcare teams. Her history as a healthcare executive has led her to voluminous national presentations on integration with both clinical and management focus, and providing consultation and training for primary care and medical behavioral health organizations, as well as developing and auditing for integrated care quality and fiscal sustainability. She develops Train the Trainer and additional educational programming for numerous contracted agencies, such as Centers for Medicare and Medicaid, National Center for Interprofessional Practice and Education, and Healthcare Communication, and conducts workshops in the area of motivational interviewing, clinician-patient interaction, team-based care, empathy, and communication to meet healthcare's triple/quadruple aims. She is a principal at Team-Based Education and Management Solutions and serves as a clinical associate professor, program director, and associate chair of initiatives at Arizona State University, Doctor of Behavioral Health program. And I've had the opportunity to attend several of Dr. Manson's workshop. She is amazing. And so we are so excited that we're able to bring her to Arkansas and provide you all with this motivational interviewing training today. So with that, I'm going to turn it over to Dr. Manson.
Thank you. Hi, everybody. So welcome. Today, we're going to be talking a lot about motivational interviewing. We're also going to take some time to practice some skills, watch some videos, and hopefully engage you all about how to implement motivational interviewing in your practices. Looks like I was muted. Sorry about that. Can you hear me okay?
Yes.
Okay. I'm just going to go over a few things that I have to for CE purposes. Just faculty disclosure, I do not have any specific conflicting financial relationships, nor will I be selling anything during this presentation, to let you all know. Also, we've got our learning objectives for today, and basically what we're going to do is we're going to review some MI techniques and interventions that you can use in care. We're going to be practicing through chat box and maybe shout outs with everybody, different pieces of integrated care. And we're going to be watching it through application of videos and talking about that as well. Okay. So I'm just to let you all know, normally when we're in person, I walk around a lot and I tell you, go ahead, throw something at me, shout it out if you have a question. Obviously you can't do that. So I'm protected by screen right now. But I do want to be able to kind of follow up with everyone if you have a question. So if something hits you and immediately you have a question, just go ahead and reach out, type it in the chat box, or feel free to unmute yourself and ask. Okay. I'm more than happy to take questions while we're moving forward. Okay. So first, as we're just starting, I want to do a kind of a pulse check. How many of you have had motivational interview training before? If you want to just put it in the chat box or shout out.
I have. Casey Copeland.
Oh, great. Thanks, Casey. Okay, so a lot of you actually have. That's wonderful. So for many of you coming in, this is going to be something it's just going to be part of a reinforcement of some of your skills. And for some of you, maybe it's going to be something very new for you. Okay, but it looks like a majority have. Okay, that's great. So for those of you who have, if there's something that you would like in specific to kind of step up as far as your skills, note it in the chat box. So as we move forward, I'll try to concentrate on giving you a little bit of that as we go, okay? And we're going to do specific interventions to help with behavior change with patients, okay? So let's go ahead and just start right here. So there's a few definitions for motivational interviewing, but the basic one is that it's a collaborative conversation. Okay, but overall, it's person-centered, goal-oriented. It's an evidence-based method of communication and care delivery that can be utilized to strengthen and build relationships. Okay, it is very helpful with motivating for behavior change in many ways. And I know a number of you are probably working with patients for health-related behaviors, or perhaps even working with patients toward improving substance use. This specific tool, as far as motivational interviewing, has found that it has 75% effectiveness when used to help change health behaviors related to substance use. That's significant, okay? So it actually has greater strength and significance than some of other evidence-based techniques. Okay? But there's a really important piece about this, is that motivational interviewing, as you start to learn a lot about it and actually practice and get engaged in some of the skills, we'll recognize that you probably already have a lot of reinforcement or training on some of those skills, like perhaps how to do affirmations or how to ask open-ended questions. But in truth, motivational interviewing is a little bit more harder than that. It's something that you actually have to train and get specific skills, because it is actually about how and when you specifically use those skills and how to use it to move that patient to the next level. Not how to blanketly use it in a conversation, but how to specifically use it to help guide and direct with the patient. So we're going to talk a little bit about that today. Okay. So as we see, there's lots of benefits for MI. Okay. As I noted, it's been effective at a high amount, and that's including actually gained effectiveness at the same levels as 12-step programs and cognitive behavioral therapy as well. MI is a style of helping others that make changes for their behavior, and it is actually included in a lot of other types of therapeutic modalities. It's similar to a guiding helping style, if folks are familiar with that, where you help the patient explore and experiment with different types of changes, and you help them move them toward a readiness to make a change. But you also view the patient as someone who's the highest competence. They know themselves the most, and you really want to work with the patient to understand their values and incentives and intrinsically help them to move forward toward that change. In motivational interviewing, compassion is key as well, and utilizing empathy very purposely is also a tool. So with this, motivational interviewing also can be used to explore and demonstrate respect and attend to cultural and individual and role differences, especially for our diverse populations. And that's really important as we're working within our communities. So MI is also trauma informed at its core, and its foundation relies on respect and acceptance of the client's current state of being. Okay? What you do is you help the patient to explore through their values and systems the possibilities of change. So I really want you to consider, as you're learning all of MI, how you can apply it within all of your patient populations and who you serve. And also recognize how the pieces of cultural awareness, equity, inclusion are fundamental to MI and how we move forward in the practice of MI. Let's look a little bit about what MI is not, though, okay? MI is not this technique where you learn something one time and you've got it down, you can rock and roll, move forward, you don't have to do it again. In fact, the research has showed that as you have more MI trainings, our version of our skills and our impression of our skills go up, but our actual skills go down unless we have continual trainings every year. So as part of a team of trainers for motivational interviewing, we have to receive training every year, multiple times a year on MI, so that we can keep our skills up to par. And actually we get registered, and all of our sessions with patients are actually videotaped and then scored on a scoring platform to see whether or not we were consistent in using MI, because of the fact that unfortunately, sometimes our skills regress. So it's really important to recognize that just learning a little bit about MI doesn't mean that you're now an expert and can keep moving forward. In fact, all the experts who are trainers, we all have to continually get MI training every year. And a lot of people might think of it as like a technique to use, but it's really a lot broader than that. And as you move through, I hope that you start to realize is all the elements and abilities that you can use with MI and apply it to various situations. Okay? And it's definitely not a cure or a magic pill. Oftentimes we've heard people refer to it in those ways as well. Or sometimes people will say, well, I'm already doing that because I already do affirmations. Remember, it's going to be very purposeful. So we're going to first start talking a little bit about the skills that are involved in MI. Then we'll actually get to the staged interventions and really linking those skills to the actual pieces of MI. Okay. So let's go ahead and start to jump on into these skills. So with MI, we have three different pieces of MI. There's following, directing, and guiding. When people first start with MI, typically your skills are going to be right on with following and guiding. What we want to do is get you to a place where you're also inherently implementing directing, okay? And so that's where that purposeful utilization of the skills is in place. So that's what we're going to move through here. And yes, Patty, right? It does. It seems deceptively simple and common sense. You got it. High five on that one. Shout out. Hi, Patty. So MI helping style, right? We have lots of evidence. In fact, MI is actually one of a few therapeutic modalities which have been implemented in every continent and country in the world and studied. So one of few. So it's fabulous results that we have and the information that we have on it, right? When we're starting to look at MI, we really need to look at that MI spirit. It's what grounds us in MI, okay? And this is what will be at the base of all of our skills as we move forward. And basically what we're doing is we're looking at the skills and practice of basic ethics as well when we're thinking about MI. It's honoring autonomy and justice for the patient, ensuring that we're inherently working with the patient in person-centered care, and always advocating and ensuring that we are looking and focused on what the patient's needs are and really embedded in their values. In addition, we're evoking and bringing out change talk and eliciting that person's reasons for change and helping to demonstrate that back to the patient, especially when they're struggling. And how we're going to do that is a variety of different ways and different interventions that we're going to actually go through today. But as you start to put MI into process, one of the main pieces that we always want to do is have a structure in place. Okay? There are 4 key processes to MI that create structure and order. In engagement, we focus in on our relationship. We know how important relationships are, and especially for first impressions. And for those of you who know a little bit about relationship research, is that typically patients actually in microseconds decide whether or not they're going to give us their trust. Okay, it doesn't take months or years. It's actually something that's innate and it actually happens in microseconds. And so we want to be able to develop that impression right away with our patients, obviously, and ensure that we continue that throughout our conversations together. We're going to take the time to establish trust and respect. And that's going to happen with that initial time in conversation where you recognize that you're focusing in on their values and that patient hears that too. In your questioning, they'll recognize, oh, I'm not here to get yelled at. I'm not here to be directed at. I'm actually having a collaborative conversation with someone who's interested in my views and what I want, which is very different than at times than what they usually get, okay? If you know some of the stats about primary care and healthcare in general, oftentimes patients have a difficulty as far as their impressions within the healthcare visit. They often leave feeling unheard. They often leave feeling misunderstood. And they actually leave misunderstanding a majority of the visit as well. So health literacy after a visit is extremely low. It's less than 30%. So that means less than 30% of a visit is actually being able to be reported back by the patient and that's understood correctly. Okay? And some of those studies go as low as 10%, which also makes you realize that's why things sometimes are really difficult in healthcare. So that's why MI significantly helps. There's been studies that have actually videotaped primary care visits where they've implemented MI training with the primary care providers and then done health literacy evaluations after to see if these patients understood those visits more, okay? And they've gone up to 90% of understood and then as low as 85. So from the 10 to 30% up to 85 to 90%. So significant changes with implementing these practice tools. Okay? And just for all of you to know, as we move forward and in specific, I will let you know that there's going to be specific practice tools that you're going to have available that you can print out, like little cards and little tiny kind of workplace tools that you can utilize that will give you reminders of how to practice MI and specific statements like this, the 4 processes of MI. Okay? So evoking is another element of MI. It's where we identify the person's feelings and emotions and those specific motivations, like I noted before, those value systems. And we're going to review specific verbiage of how you're going to bring that out with a patient and specific questions you can use. Okay? Just remember there are these processes of engagement, establishing that partnership and relationship, that focus piece of developing a specific direction with the patient and helping to maintain it with the patient. So when the patient goes off into a different direction, you can bring them back by a reminder of what was important to talk about today and why it was. Okay? So bringing that focus and returning it. Evoking is where you elicit motivators and feelings about that change and use it by that value system again. And planning is that end stage, which we'll review interventions related to that as well, where you're making a commitment to the change and developing a plan that has SMART goals, that's measurable, time-bound, that you can follow up easily and a patient can report out on easily as well. And a plan that meets their needs. So perhaps not a goal of running a marathon, but perhaps a goal of walking to a mailbox. Okay. So let's go ahead and start with the first kind of common, deceptively simple skills in MI. Okay. So the first skills is ORS. ORS stands for open-ended questions, affirmations, reflective listening, and summarizing. Okay. We all know when we ask good questions, and we all know that's part of effective communication and how we develop a relationship with a person in care. And it's how we actually get more accurate information. But in order to get the best information, we take closed-ended questions and we also align them with open-ended questions. And sometimes we have to evaluate whether or not the closed-ended question is giving us enough information for us to actually have accuracy. So for example, a common closed-ended question in healthcare is a question such as, are you taking your medication? How often do you feel that patients perhaps say yes to that? What do we think? Is it all the time, some of the time, 80%? Anybody want to put some percentages out there? How often do you think patients say, yes, I'm taking my medication when asked? Just thinking that I'm looking in the chat box. Let's see some responses. Patty says 90%. Did I put you in there, Patty? Yeah, Jared, you got it. Okay. Yeah, you were all about right. It's about at that 90% level. So you got it. Okay. And that's interesting because the percentage of people that are taking their medications accurately or adherent to a medication and actual behavioral recommendations from a medical plan, what do we think that's at? What's the percentage of those who are? What are we looking at? Anybody want to try to guess on that one? It's definitely not 90%. And unfortunately, it's actually more common that patients aren't adherent than they are. Yep, you're all implanted there. It's like you all, those are all folks, all good on that healthcare literacy. Yes, you've got it. It's about 30% and sometimes a little bit more, but it's around that range. So you all are right on in that 30 to 40% range. That's right. So obviously, if this is a standard question in care of, are you taking your medications? It really does us no good, correct? But yet we're asking that every day in primary care and medical care centers. So that's where we want to take a look at these questions and see what's an alternative. How can we make it so that we actually get the information that we need out of that? Okay. So one way to do that would be to look at a step up of an open-ended question related to that. Okay. So oftentimes, just to give one example here, I'll give an example of an open-ended question that might be something like, tell me about the times where it's difficult to take your medications. Okay. So I want to elicit a story. And I'm also assuming that there's some challenges, certainly. Okay. But I'm wondering if anybody has any other questions for open-ended questions you want to shout out in the chat box, go ahead. Okay. But let's take a look at some of these examples. Okay. So basically, open-ended questions, for those of you who are new to this and maybe unfamiliar, it's a question that can be answered with a story, an open-ended question. Okay. It's not a single word answer. So it's not a yes, no question, or it's not a 1, 5, 4, Monday, Wednesday, Tuesday. It's a question that asks them to explore a little bit more. So you're going to have what we call common constructions or threads, okay, or starters like tell me more about, okay, or how your med's working. Thank you, memory. And what days did you? What was it like to? Okay. So it expands that question to get a little bit more information. One thing I will say here is that oftentimes people are scared and cautious to ask open-ended questions. Okay. I'm sure you can all recognize maybe the reason why is because we have a tight timeline. In care as providers, we actually have to meet specific standards and structures related to our time. There's never a time where we're like, oh, I have nothing to do. I'm just going to sit back for the next few hours. Let's see who comes in, right? Normally, there's a lot on our plate. Even if there's a cancellation or no-show, what occurs is phone calls, emails, right? We want to check in with patients who didn't no-show or who did no-show, I should say. So we have a lot of other obligations that occur. So the fear is that by asking open-ended questions, it's going to take too much time. And then what's going to come out? Will we have enough time to deal with it? Okay. So what we know as far as practice, and the research has also confirmed it, is that we do have the time. Most patients more often won't take all of that time up. They will answer, and if they start doing a story, you use the MI techniques to also bring them back. Okay. So at times that also means you might need to kind of do a visual technique and then pair that with specific verbiage to help them recognize that you need them come back for a second. So we're going to go over some of those techniques as we move forward, but just know that it is helpful to do these open-ended questions, and it's not going to result in significantly more time, okay, for you. What it will result in is significantly improved answers and knowledge of your patients to help them to move forward. Okay. So here's a few ways that you can look at and encourage the person to talk. Obviously, these are more stems or common construction questions that you can use. Tell me a little bit about your use of heroin or pain medications. Sometimes people are cautious about questions where you're asking them to give you more information about something that they use that's harmful for their health. But that's really important. You want to get at what do they like about it? What's part of their values that is aligned with using? Or maybe you'll find out what's not part of their values or what's misaligned with using with that question too. But that's really important to ask, okay? So consider what types of questions you might want to ask for your patients and how that might benefit you. So I often challenge people to think about those closed-ended questions and switching them over, okay? Let's look at a few more of the open-ended versus closed-ended questions so you get a little bit more of the examples on it, okay? So if you think about this, if you say something like, can you tell me about the downsides, right? You get a little bit more viewpoints about what they are challenged with and what they already see. It goes a little bit to stages of change, which we'll talk a little bit more about later, okay? So questions like, what are some aspects of using that you're happy about? What are some aspects that you're challenged about or you don't like about using, okay? How about, was there a time when you weren't using? What did that look like? Okay. How did you feel then? Were things different? Okay. Were things better? Were they worse? Right? Sometimes people will choose specific types of stems or questions that they'll ask on a regular basis that feels comfortable for you. Some people like to ask the question of, were things better? And some folks like to leave it open-ended of, were things different? Okay, so they can explore it a little bit more and then identify it and move it forward. So other types of stems would be things like, in what ways, or tell me more about it, or what does that look like? Or when was the last time that happened? And tell me what was happening during that time, okay? So you can take closed-ended questions that you're traditionally used to and then expand them to be more open-ended, okay? There's also an element of open-ended questions where we ask this, explore extremes. So what are some of the worst things that could happen if you blank, continued down this path, if you continued using, right? We do reinforce to be very specific and clear related to the question you're asking, because oftentimes patients have a lot of health conditions and a lot of things that they're experiencing every day. So when you ask them about something that might be challenging, they might be thinking about another aspect of their health, and you're really only talking about a different one. So it is helpful to be really specific on that. So whether it be about weight, whether it be about managing a specific goal, whether it be about hypertension, it could be about managing HIV or sexual practices, it could be related to substance use, right? No matter what it is, consider being very specific and directive related to that question, okay? So in open-ended questions, we look at, again, exploring more person's reasons, their values, by doing these exploratory or open-ended questions. We're going to look at pros of change, okay? Pros of staying the same. We're going to look at con questions, cons of staying the same, and cons of change. We're going to do questions about looking backward or looking forward, okay? We might ask for examples about their day and their experiences, and then we may explore extremes. Those are the targeted areas for MI when we look at open and closed questions and how to utilize them. Okay. So again, I'm just going to say it one more time. Cons, pros, looking back, looking forward, asking for examples, and exploring extremes. And again, you're going to get some hint cards about that, just for good reminders about how to gauge those open-ended questions. Okay. And remember, the impact here is thinking about those conversations and making sure that you get that story. Okay. And so you take them out of a feeling of being interrogated or this kind of choppy questioning, and you're really listening and being with the patient. And oftentimes patients report feeling more heard and valued when they're actually engaged in an MI conversation. Okay. So now let's take a look at affirmations. Again, this is another skill in MI, affirmations. Now, many of you may already be trained in affirmations, but here we want to use them very purposely. Okay. In affirmations, we offer support and encouragement in specific. Okay. When we do this, oftentimes people will communicate appreciation for the discussion and the note for feeling understood again. They remind the individual that they are in control of their own choices and that our role here is really to support them. It is not our role to give them what they're going to do, right? It is our role to work with them, that they are a part of their own healthcare team, right? And unfortunately, many patients don't feel that way. In this time, sometimes you statements are used often, okay? You're feeling this, you are a strong person, right? This is the time to really be able to use affirmations to recognize and encourage a person's strengths. Okay. I'm sure many of you have specific affirmations that you regularly use with your patients, but it's important to consider using them very purposely, knowing that it's going to help you to move that person toward change. Okay. So soon we're going to link all of these steps with specific stage interventions. Okay. So again, we're emphasizing strengths instead of weaknesses here. And believe it or not, most of us don't get a lot of affirmations in our days, especially if we're challenged by healthcare. If we are challenged by our substance use or other types of choices, more likely than not, we are faced with individuals every day that are looking at us or commenting at us in derogatory or negative ways, or we're just faced with different challenges within our community. So having a moment where within your healthcare, you feel affirmed, you feel listened to, and there's empathy, that's what's going to help build that self-efficacy and that piece that's inherent and important for the person to change. So we know one of the highest variables of change and whether a person is able to change is self-efficacy. Next is the relationship, not first. It used to be that we didn't research actually self-efficacy. And so we only looked at the therapeutic relationship. And then the research came out about how quick we actually do engage and have therapeutic relationship within microseconds more often than not. Okay. And then we found that self-efficacy is actually the highest correlation for a person's ability to change. Okay. So let's keep moving on with some of these and recognize some of the next areas to be able to provide skill in MI. Reflective listening is that next piece here. Okay. This is where you're going to be listening very carefully and reflecting back, but it's actually a little bit more purposeful. So in client-centered care, oftentimes, if you've learned that therapeutic modality and technique, you learn that you do a lot of parroting or phrasing back from what the person said or in their own words. We definitely want to use the same pieces here too, but we want to use them more purposely. So inside your head, as that professional working with your patient, you're constantly recognizing what is the best thing to reflect back to this patient here. So it's not the last thing that they said. It is to go in and to consider what is important to reflect. What do I want to reflect that illustrates something that may be a value or something that would be related to a change talk or sustaining change? So that's what we're going to look at. We're going to look at reflections that are purposeful, demonstrating values, demonstrating change or sustaining for change. Okay. So we're going to look at those types of words and phrases. So some stems related to that are things like, that might be difficult, okay? Or I hear you're upset, or sounds like. Those are the easy kind of first elements of reflective listening that most people are feeling comfortable with and engaged. That next higher level of reflective listening is where you're going from the simple reflections, okay, to then where we want to go toward the higher level reflections, where it's more toward those values and helping the patient see that there's a change coming. Okay, so we're going to put this all together here soon. Any questions on ORs thus far? Okay, we're going to go right into summarizing, which is our last piece here in ORs, which is about sounding. It's basically helping that patient feel that they are heard by giving a summary or a recap about it and checking in with them that it's correct. So validating them with an ability to actually correct you and give you permission as far as being able to correct and make a change if there's something wrong. Okay. So in the summarization, it's also really specific. The first stage and beginning stage of MI with summarizations is the same thing like the simple reflections. It is just going off the patient and saying, oh, okay, I'm going to summarize a little bit about what we talked about. Okay. So it sounds like you might be interested in quitting, but you're not really sure yet. Is that about right? Right. It's kind of an intro piece to it. Okay. Then as you start to refine your skills, so many of you already on this webinar have MI skills there. So for those of you who already have those developed skills, here you want to take a step up related to your summarization. Just like in the reflections, we want to withhold general reflections and actually only give reflections that are going to be moving that patient forward in response to validation, okay, and identifying values and specifics, and then illustrating the change pieces, whether it be change talk or sustaining for change, okay? Then in summarizing, we're going to implement that here too, okay? So we're going to be a little bit more directive, and we're going to go straight to that last piece of intervention with our summarizing. So instead of just staying here of, oh, it seems like you might not be ready, and then ending a conversation, you're actually going to go straight to, what do you think about hearing a little bit more about resources? Okay, go straight to the intervention, which is aligned specifically with their stage of change. So that's where we want to start to move more of you toward, considering more of you have already had the MI. For those of you who this is the first time, we're going to be thinking about just having that generalized reflection and making sure to ask the patient, hey, do you mind if I give a little bit of a summary statement here about what we talked about so we make sure that I got it right? Giving the summary statement and then coming back and say, great, did I miss anything? Anything else you might want to add? Okay. These are ways that you're actually going to engage with a patient to move forward a little bit more. Okay. So that next piece is the planning stage. Okay. So in MI, as we're moving through and we're doing each of these techniques, we really want to apply them all to making sure that we get to the planning stage with the patient. And this is where you're going to ask them about a decision. And it's really important that that occurs within every visit. So this is that adage of always give something to the patient, right? Always provide them with something. So this is where you want to show empathy. Okay, you empathize with any difficulties or any other aspects of the communication that they gave you. And you specifically ask about perhaps, how can I help you to get past some of those difficulties? Is there something else that I can do to help make that decision? Okay, what could you do to reduce these problems or these concerns, okay, on deciding what to do? Maybe it's directed toward a barrier in specific, okay? You were just saying how that you wanted to do X, Y, and Z, okay? If you decide to change, what would you like to do today to help move you toward making that happen? Or after talking, is it a little clearer about some of the things that you could do? Okay. You want to ask a specific question to the patient so that you can either go toward a specific planning piece and have an action plan and a goal, that SMART goal, or are you leaving the patient with an open-ended conversation without that direction piece there? Okay, that's the deciding point in MI when you're getting to this stage. So at a more kind of a little bit more moderate to expert MI phase, you're going to be doing the asking a decision right away with a patient, okay? And you're going to be linking that toward a specific goal or SMART goal as soon as possible. If you're a beginner, then you might want to do an exploratory question that is still asking about that decision, about you're trying to decide this, what would you do to make it happen? How can I be helpful with that? Okay, and giving a little bit of exploration. So in the planning stage, these are the types of questions you want to implement. So let's take a moment for a second and think about everything we just heard at this point. This is the beginning stages of MI, which is the spirit of MI and ORs, okay, moving through. So you have open-ended questions, affirmations, reflective listening, and summarizing. And we've also noted how it's really important to recognize when and how you're doing each of these. So it's not a blanketed, I'm going to repeat or parrot or provide a summary every time. It is, what is useful and when is it important to do it? Okay. And so constantly when you're engaged with a patient, you're also engaged in your mind about thinking, okay, they just said this, I'm going to put that in the values piece. I'm going to hold on to that because I want to bring that out as part of my reflection. Okay. Oh, they said this, I'm going to move that to summary and I'm going to bring them all together maybe in a statement that has a reflection, a summary, and ask them about their decision all together. So instead of doing them separately, I cut the chase all the way down to that one kind of phrase that I'm going to be giving them in the end. Okay. So it's very purposeful as you're sitting with a patient to be able to think about each of these pieces. Okay. So I just want to check in with everybody and just do a shout out for a second about, first, let's look at in the chat box, how many of you have specific closed-ended questions that you have to utilize in care? Do folks have closed-ended questions that you have to utilize? And if so, if anybody would be willing to put it into the chat box and maybe try to identify an open-ended question that gives you those answers and actually gives you a little bit more value to it. Okay. So the challenge for you all is to consider what closed-ended questions you use in care now, and then what's that open-ended question you could change it to. And I'd love to see some examples in the chat box from all of you. I know I said a few earlier, okay, but it's really important for you all to consider, what are you comfortable with? You want to obtain those stems for yourself. There's certain questions that I really like, and there's others that just feel uncomfortable for me. You all want to find those things too, okay? How are your meds working? Okay, there you go, okay. Do you smoke? That's a great one, right? Change to, how does smoking make you feel? Yeah. What do you like about smoking? Okay. Tell me a little bit more about that, right? So never be fearful to engage about what do they like about an unhealthy behavior. Okay. That's really what we want to know. We want to learn that. That's inherently very important for behavior change. Okay. So always ask those questions. Okay. More change. Okay. Yep. Change to, how does smoking make you feel? Frequency, duration questions, and substance use. Yes. So memory, right? We always need to ask that, and maybe about a story in that. So a switch could be, tell me about the times where you end up using more, or what does it look like on those days where you are using more, or when blank, you know? Is there anyone in your life you need boundaries around? Okay. Okay. What's your DOC? How has it affected you, your world? Where might you need to set boundaries? Okay. So a lot of folks have already, looks like, developed a lot of open-ended questions. I'm hoping people are seeing this and maybe even jotting some questions down yourself and saying, I'm going to ask that question next time. I like that one. Okay. This is a time to share a little bit. Okay. Okay. Let's go on and look a little bit about motivational interviewing and jump right into a little bit more of the skills. Okay. And as people are putting in more questions, so I really want you to keep going. And if I see one and you don't have an open-ended, I'll go ahead and offer an open-ended question to that too. And at this time as well, I want you to consider some of those challenging patients you all have, okay? Because in a little bit, we're going to be talking about how to utilize MI with those challenging patients, okay? So I'm just going to say, Duana, she says, do you really want to stop drinking? Open, how does it make you feel when you're drinking? Okay. And so we're also going to talk a little bit about some scaling. So if you look at the skills list here, we're going to discuss some of these pieces of it, including that assessing at the bottom, which is using scaling. So let's go ahead and jump on in. Okay. So a few helpful MI techniques are to listen to specific things like what we call hearing for change talk or sustained talk, okay? Targeting ambivalence, targeting values. You'll hear that a lot in MI. And there'll be a lot of specific targeted kind of trainings just about that, okay? Of how to listen for it. What are those words, those phrases, okay? But basically, what you want to do is just listen to the patient and hear where do they say something that you recognize as conflicting with their values, okay? Or there might be a worry or a concern that could be associated with that behavior that you're looking to change, okay? So that's what you're looking for, is you're listening for that in various conversations, okay? If you find yourself go off track with a patient, or maybe the patient goes off track, you use MI to bring them back. And that's where you go back to the original statements of focusing the patient on what they wanted to talk about today, okay? What was the topic? And you bring them back. So if they went into a longer story related to using or some other question that was asked about for their change of health behaviors, then you're going to bring them back and say, I want to time out, or I need to stop you for a moment. And we always say, do something where if you're in person or even on a video screen, sometimes it's helpful, okay? Lean in a little bit, note to them physically that you're interested and you're listening to them. Give some sort of a visual sign. Maybe it's hold on for a second, okay? Or timeout. I don't know how many of you use different visual signs, but if you have one that you use and you love to share it with someone, go ahead and put it in the chat box as well so others can learn about that. But you use the sign and you refocus that patient back. And in specific, whenever you're refocusing the patient back from a story, refocus them right onto something to do with change talk in general. So I want to bring you back. I know that you're talking a little bit about this story, and it sounds like it was really exhilarating for you, or maybe I'll use a different word. It sounds like this was something that was important to share, but I wanted to pause you for a second because I'm fearful that we might be getting off track from our original topic of this, okay? I'd like to come back to the story if you feel comfortable with it at the end of our conversation or today or whenever, and I even make a note on the page, and then I focus the person related to that talk. What was really important for me is I heard you say this, okay? And I give them that change. I heard you say that what's really important for you is to be able to do X for your kids, or show blank this, or be a blank, or get a blank, right? Something that I heard that might have been a goal or a value or a worry or concern, be fiscally stable, okay? Whatever that might be, stay alive, okay? Not be drunk at the dinner table. Tons of things I've said with my patients that they've said to me. So I'm going to be parroting back something, but in specific, I go back to that because it's talking about change. So whenever I'm bringing a patient back from a story, I pause them both verbally and visually, and then I bring them only back to that sustained talk area of talking about that change and where you want to go with that, okay? So always remember that's an important piece, and you could be noting perhaps like a barrier to that. You had said that this was difficult. I want to go back there because I want to talk a little bit about those barriers and how to help you with those. Be purposeful and directive. That's how you start to move that guiding and facilitating the conversation to being that directive piece with the patient. It's also really important to recognize we all have a writing reflex within us, okay? It's pretty normal and common, okay? That as healthcare providers of different ways, we all have knowledge and experiences that we come forward and we're with our patients and our communities about, right? So if I'm a peer educator, I come with a variety of experiences that I bring and I communicate with our patients, right? And with my community. So oftentimes we'll have specific kind of values that we keep and share, and specific things that we might think are right or wrong for us, okay? And so that leads us to something called the writing reflex, where oftentimes as healthcare providers of any kind, we have this value system ourselves. And when we hear someone that says, oh, but I just want to use anyway, and then we might have things like, oh, no, that's bad. You can't do that, okay? That writing reflex, okay? Well, doing this isn't really going to hurt me. Well, yeah, it is going to hurt you, okay? That jumping in and being responsive, really quick about it. That's what we really want to hold back from. And obviously I have a picture here. If people don't know, I think it's Judge Judy, right? Or one of those judges. And she'll often do this thing where she'll do her finger and give someone this kind of advice straight out. Okay? And it's not that you're not going to give direction or advice at times, but we want to take a step back from the writing reflex. And if you find yourself doing it, that's fine too. Stop yourself, right? If you recognize it and in your mind, you just realize, oh, what did I just say? I just did it. Correct yourself with the patient. Say, you know what? I want to pause. I'm sorry. I just realized that I said that. And you were telling me about how that's a choice for you. I want to let you know that I respect that. And I'm glad that you told me that. Where that statement came from is that feels incongruent for me. Okay. With my training or my experience, is it okay if I tell you a little bit about the reason why? That's where you can work on making the change if you did a writing reflex and bringing it back. Okay. That's that intervention there. Otherwise, if you're hearing a patient and they're really giving you some resistance, which is where sometimes the writing reflex comes in, instead, what you want to do is an MIT technique called roll with resistance. Okay. This is where we just kind of roll with it. Okay. And so you're going to hear it. It's one of the techniques that's actually the most often hardest to follow. Okay. Especially when discussing change, okay, with patients, is that you're going to have folks that resist treatment and suggestions. Anybody have ever had those patients that are resisting? They don't like it. Yeah. Right. Okay. And what are some of the things, if you can think about what are the things that they challenge you with saying, put them in the chat box so we can see them. Okay. But oftentimes they'll say things like, well, that's not going to work for me. Right. Okay. I did that and that didn't work. Right. They'll be resistant, or no, when I don't have any of those bad problems. Right. My world's actually, greater and better. Right. I see unicorns. It's all positive. Right. I got raises in my job. My family is even better now. Right. It's very opposite or incongruent, right? Oh, right, Jenny, that's a great example, right? Mania is so much better than depression, okay? So these are great examples. If anybody else has some, put them in there, because I know we've all probably experienced them at some point. These are things that sometimes we want to write, right? That's that writing reflex of like, well, let me tell you a little bit about some of the consequences of mania, or mania can't be better because you also have these things. Do you remember when you did X, Y, and Z, right? Okay, that's that writing reflex. We're going to hear to like mirror something really quick. We want to roll with it before we do anything like that. And if you're going to give that other side, you can, but you want to do it purposely. And I'm going to give into that in a little bit, okay? But here, what we want to do, okay, is just roll with it. It's, oh, here's another one. I don't want to be here. I have to be here. Okay. So just rolling with it. Okay. Well, since you're here, what are some things that we can do to really concentrate on making a change? Or what are some things that we can do to help you be more comfortable being here? Okay. It might be shut up, right? Okay. It might be actually more aggression at times, and you roll with it. The importance is not to overpower the patient, okay, or become more judgmental, or become more reactive with the patient. And sometimes patients actually are giving that to us to see how much are we really going to give? Are we really going to stay with them? Because patients who are in our community members, our friends or family members who experience challenges every day, right? They don't have a lot of folks that stay with them, okay, that can handle them, that can really listen. They're used to folks really hitting them hard and moving on, being like, oh, you're not worth it. You can't do it. Okay. And so they will challenge you. They will do that to see, are you going to stay? Can you take being and sitting with me? Can you take hearing some of those challenges? Okay. Can you take that time it's going to take to help me make this change? Okay. So accept the challenge and just sit with it and roll with it. Okay. Well, I'm going to be here and I'd really love to use that time. And I can talk to you a little bit about some of these things. Okay. So it may mean that you do a reflection of perhaps something else that needs to occur. Okay. That maybe it's mandated if there's mandated care involved for some of these patients, right? It may be that you give some information about what you do or what you can do, or you go with any other types of goals or change. But you're always rolling with the resistance instead of trying to overpower it, okay, or hit it face on. That's when we're going to lose a patient and lose that ability to get them to that next step. Okay. Any questions on the role with resistance? And another aspect of it is you can learn from the patient during that time and just ask them to tell you more about that. Okay, give me some, I'd like to hear a little bit about when you say that it is much better. When you say that you don't want to be here, tell me about your experiences in the past. It sounds like they haven't been really good. We don't want to do that. Okay. I know that you have to be here, but perhaps we can make this different than your last time. Okay. So do that exploring, switch it, roll with it with the person. Okay. Oh, sorry. Sorry, my clicking went a little bit too much. So let's keep moving here. So one of the other aspects is related to asking and don't tell. Okay. We don't want to just tell a patient. Inherently, we want to ask permission. Okay. And that's really important. Okay. Asking permission. Asking permission actually leads to patients listening more and understanding that health literacy at the end of the visit for them to be able to understand what happened in the visit and be able to learn from it and know what they're doing next occurs here. When you ask a person, they actually listen more. So they go, oh, wait, oh, you're asking me if I can do that or if I want to hear about that? Oh, yes, I do want to hear about that. So then they focus in. Without that, they may be more focused in on laundry lists, right? What they have to do, their other health conditions, other challenges, the kid behind them, the dog barking in the distance, right? We all lose track of that. So we need to really consider this piece. And this is another MI specific intervention of asking, don't tell, always ask permission. So as you give anything, you ask permission. Is it okay if I tell you a little bit about what other patients have done? Oh, sure. Right. Is it okay if I give you blank? Okay. Whatever it might be, but find a way that you like as far as your stem for asking permission. I use that. Is it okay if a lot? Okay. But everybody has a different piece about how they do that. Okay. This also gives the patient that piece of autonomy where they are actually more in control within the visit and the conversation, where they are actually a part of their healthcare versus you being directive and only talking at them, perhaps, or being seen as only a person of authority. It levels that playing field. So they're with you again and takes away that piece about lecturing that oftentimes patients will feel as well. Okay. So basically, we're demonstrating more respect each time. So these are some of the techniques within targeting ambivalence. Okay. So even using that writing reflex, the asking permission, we want to use those techniques with that too. Okay. And with MI, we're going to be listening for that ambivalence because that's part of that change and that change talk, right? We're going to be listening. What are they saying? Maybe they say something about their child or friend that doesn't like them using something or doing something, or is uncomfortable with their health in some way. If you hear that, you want to go right there. That's where you can bring a story back or bring a visit or a conversation back to. I remember you said that so-and-so had made this comment that they're concerned about your health too. Tell me a little bit about why they're concerned about their health. Have you ever talked to them about that? Right? What in specific? Okay. Get to that ambivalence so that you can see that and recognize too, is there anything with their values that align with that? Maybe they have a value about being a good parent or being a good friend, right? Or being a member of a community. And so having a behavior that's incongruent with that, you can actually work with that with a patient to illustrate how that's inconsistent and help them to see that and hopefully move toward that change behavior. Okay. So motivating someone towards change. Okay. It comes with the patient being able to recognize that mismatch, that incongruence with where their situation is and how they see themselves or their values or where they want to be. So that's what we're looking at here. And that's why we're trying to do it. You also can look at it with exploring life values and goals very explicitly and asking specific questions about that. Okay. What sort of person would you like to be? What sort of things would you like to do? Okay. How does opioid addiction fit in with these values? How does heroin addiction, how does using the pain medications fit in with these values? How does blank, right? we want to specifically put a question in there that's going to get at that question related to exploring the life goals and placing the value system on it. So consider that STEM for yourself too, another one. So in another way, we're bridging and bringing out discrepancies, okay? We're bringing that out and highlighting. Okay? Sometimes people with MI will also talk about this decisional balance piece, where you'll see this character that's kind of going back and forth with their hands. And part of this tool with targeting your words and your questioning and using those open-ended questions, okay, is that you're targeting and demonstrating that ambivalence that you heard, that inconsistency you heard, and showing it as a discrepancy. I hear that you say that you have these goals, but on the other hand, you're telling me that you're using X, Y, and Z every day, and it's causing problems. It sounds like it doesn't make sense, or it sounds like, you know, this is really challenging and prohibiting you toward that. Or what would happen if you didn't change? What would happen if you did change related to that? Okay. So you're very specific with really illustrating that reason of that imbalance, okay? And then the reason to change. What is that goal or highlight? What is that value that you're going to bring out related to their future? Okay. So as hopefully you're hearing that, you can see how some of these tools and techniques and skills in MI might seem simple, right, and easy, but it's actually really purposeful about how you're using them in conversation. Okay. Empathy is another tool. Okay. Oftentimes people will feel like, oh, I'm an empathetic person. Maybe you're a counselor or a therapist in some way. So inherently you probably use a lot of empathy, or you might be an empathetic person in general, right? Oftentimes that can be the case, not for everybody, but empathy is actually something you can learn and practice to be able to demonstrate, both with our words and also with our nonverbals, okay? So that's really important that we recognize that and we practice it too in MI. So we want to empathize with concern and we want to explore. And that's that piece of really recognizing that respect for the patient and knowing that they are the ones who know themselves the best and being able to identify that and bring it out. And you're just a reflection back of them really ultimately, okay? But coming there with that respect rather than with the judgment. Okay. Has anybody ever been maybe witness to a patient healthcare provider interaction where you saw that that lack of respect was there, or that there was a judgment there that maybe people missed? Perhaps they said something or commented about drug users or drug using, you know, or, you know, oh, you know, like some comment about someone who has a health behavior that they can't change. Has anybody ever experienced that? Just checking in. I see some cameras here. Somewhat. I've seen it a lot in healthcare. I hope that we don't see it very much at all, but it does happen. So it is important to consider kind of developing your own pieces related to empathy. What are the words you're going to use to express it? How are you going to recognize and express respect to the patient, okay, and the person you're sitting there? So really emphasizing that, and actually even consider your nonverbals. Oftentimes we might even not be aware. Jeff says yes, unfortunately, yes, yeah. Sometimes we might not even be aware of what our nonverbals look like, okay? I've been in rooms doing some of these trainings where we practice nonverbals, and specifically the nonverbals that are actually correlated to displays of empathy with patients, okay? And so when we practice those in specific, I've actually had other like staff members turn around and be like, oh, you know, Lesley, that's that resting whatever face that you always have, right? Or, you know, so they'll actually call out someone, a colleague, a staff, a friend or member about their nonverbals that they have. And I've had people say, I didn't know I had that, right? Or, you know, folks that they stand with their hands always kind of like this because it's comfortable, right? Not because they're trying to be powerful of an authority, like, I'm going to do this, but for them, it's just comfy, right? So there might be stances that we have that are actually illustrating and giving a incorrect or inconsistent message from what we're trying to communicate. And unfortunately, nonverbals are heard more often, 99% of the time. So amazingly so, as much as we can try to make up with our words, if our nonverbals are demonstrating something different, it's very hard to convince someone the opposite, okay? So practicing those nonverbals are really important too. So I'm going to encourage you all to consider doing that, stand in front of a picture, a mirror, and really sit there and practice. What do I look like? Maybe ask some of your colleagues to do that with you so you can really just check in. What do my nonverbals look like? How am I operating here? What is the challenge? What am I really good at? And when am I demonstrating that empathy and the empathetic nonverbal so someone can actually hear what I'm saying? They can feel it better when I'm doing it. Okay. So just to give you a few of those pieces for the nonverbals, for women, it's typically head tilts. So oddly enough, individuals that are female, and actually they've linked it, they're actually doing studies right now related to individuals who have transitioned and recognize that some of their nonverbals are actually changing more. Okay. And so it could be linked to differences in hormones. There's a lot of dispute about it and conversation about it right now. But females tend to tilt their head when they're listening. And it's a demonstration that they're actually listening and engaged rather than straight, okay, necked. And so they tilt their head just slightly. Okay. So that's one way that you actually reflect back to the patient, is that you tilt their head. You actually lean in as well. You can mirror sometimes their stance, but if someone is actually feeling defensive or on guard, their stance is not perhaps something you want to mirror, because now you're mirroring a stance of being on guard and being defensive, right? Which means that you're unfortunately meeting them to then go escalate. Okay. So we really don't want to do that. We really want to have an open posture. Okay. The best is to have our hands down and not in our pockets, or not, with our hands crossed. Oftentimes that people do relate that feels uncomfortable. So that's where that practice comes into play. And then also relaxing the muscles in your face. There's been experiments where providers, before going into a room with a patient, actually did muscle exercises for their face. And they've done research of whether or not these patients felt like they were more heard, or there was more empathy in those visits, but right after they did those exercises. Because we tend to experience a lot of tension every day when we're in care and we're working in healthcare. I don't know about you all, but it's very tense, and that tension has escalated, okay, to a large degree. So we wear some of that in our muscles, and especially in our face every day as well, okay? So that's an important piece, is to consider that. If anybody aware of the muscle exercises that they recommend, just to kind of check in to see, does anybody do any muscle exercises with their face? Heard of it? Okay, I'm seeing a lot of no's. Okay. It might seem silly, but these are techniques that we teach in MI. Okay. And some of those techniques are things like muscle exercises of like, okay. And so we have little funny nicknames for it, like scary cat. Okay. And so we do these things almost like yoga poses, where people will say like cow, things like that. It's going to be very similar. And so basically it's scrunching the muscles in your face as much as you can, and then releasing. So if those of you who might be familiar with progressive muscle tension as well, it's very similar to that, okay? And that's basically what you're doing related to here. You can also do the progressive muscle relaxation techniques if you'd like for your body. Obviously, that will help with stress in general every day if you did that, but it also helps to be able to express those pieces of empathy, okay? So Jefferson says, I try to recognize if there is tension in my jaw, and if so, I work on relaxation technique. Yeah, that's really important. Again, most people miss this. So this is a great technique to consider. I have had a lot of folks where after a brief webinar like this, this is an introduction, right, to these techniques and tools, they'll come back and say, now, before I go into every visit, I kind of like check in with my face and think, okay, am I feeling tense? And just loosen. And then I go in. Okay. And so it's something to consider. Okay. Kim says, exhaling with a hard H sound. Am I breathing? Yeah. And that's part of that piece of kind of diaphragmatic breathing, or also yoga techniques for people who understand those, that piece, right? And so those things are really helpful. So what people miss about it is you might think it's general self-care, but it's actually tied to our own expression and how we're communicating with our patients. Because again, nonverbal communication is 99% more effective than verbal, okay? So it's really an important piece of this too, when we're thinking about putting everything together, okay? So focusing on all these skills, the bottom line of what we're doing here is we're building self-efficacy, okay, with our patients. We want to recognize it and know it, Okay, we're going to pull it out as far as what their values are. Okay, but that's what we need to do because of how much it's tied to that behavior change. That's why we're here doing this. Everyone must have a belief in themselves towards success. We also have to be realistic in defining that with the patient or the person. Okay, so that's true too. Another skill here is focusing that change talk in our conversation so the person can see that they can be successful, right? So bringing it out so they don't always stay in that stuck area. Because I don't know about you all, but with most patients more often, they experience that stuck environment, especially in that area that you might be talking to them about. They felt stuck more often than they felt motivation or success. So highlighting that they can do it and how and what that's going to look like, and that they have it inside of themselves to do that is very important. That's how we do that. And we're going to do that through all these reflective statements that are very purposeful, right? We're going to do that when we really are highlighting how they're going to move toward that ultimate goal and what we see in them too. So it's also important to use that relationship here with self-efficacy and promote that person's belief, okay, of success, that they have the ability to do it. And sometimes it's letting them know what we feel about them or what we see within them, okay? And that's really important too. Does anybody have statements that you use now that reflect promoting self-efficacy, that help build their ability to feel successful, that they can have a belief in themselves towards success and do it? Does anybody have certain things that they say, or maybe statements or questions they use for change talk? So always think, if you're wondering, I don't know a statement, right? Always think, what is that piece about change? Okay. What is it that motivate them? Tie that in, that value system for them. Okay. It always goes back to those pieces. MI has been always focused on value. Okay. And highlighting it and bringing it out. If you know something about an experience for them, if you know something that they want to do, but perhaps even if they have not accomplished that, what do you see in them that they can accomplish that? Okay. So memory says, wow, that's a lot of insight. Yeah, right. To bring them in there and to do that. And it's hard. And maybe doing that phrase to them, right? Like, that's a lot of insight. You can do that. Like, I can't believe that, right? So those are things that you can do as far as phrasing. Okay? But you want to build it for them. And sometimes people get challenged with different populations that have actually been met with more struggle than success, okay? And that their environments have geared that. They were born and raised in an environment that was constantly putting them down, okay? Constantly putting barriers there rather than opportunities, okay? And that's unfortunately true for a lot of our communities, okay? And so it's really important to recognize that that can be a challenge at times, okay? But then you have to say, what are those phrases? What am I going to bring that out? Even if it's something that I see. When I look at you, I see someone who has X, Y, and Z. I see someone who's very strong, especially if they're strong-minded and willed, right? Even if it's in the other direction, telling you what they don't want to do and that they're never going to do, that's some strong will, okay? And they obviously can use their words well, okay? Even if it's derogatory at times. I'm going to focus in on that as a strength and talk about how they can use that to elevate themselves, okay, and move themselves, okay? So consider what those challenges and what some of those phrases might be for you too, okay? So the next element here for MI is related to using what we call frames, okay? We have a lot of these kind of terms and acronyms that we use in MI. This will be the last main acronym I'll introduce you to. The next ones are going to be for more targeted pieces of MI and really specific learning. Here's another one that you can really kind of learn and then understand and start to implement, even if it's just pieces, right? Even if it's just implementing, like earlier, open-ended questions and implementing a few more of those this time, reflective statements, being purposeful with summaries, or maybe you start to structure a little bit about a conversation structure and you use frames to do it, okay? So this is a way to frame and structure a conversation. Okay. So let's look about what that looks like. Okay, so first in frames, it's feedback. Okay, which is again, using some of these pieces that we've already talked about gets pulled in here. It's non-confrontational, right? It's really supportive, it's client-centered. Okay, you use things that are going to be words that are going to be easily understood. Health literacy and literacy levels, as far as our verbiage, is going to be lower. So usually we recommend at the 2nd and 3rd grade level for all of our verbiage that we use to communicate. Okay, so it's also going to be culturally appropriate. So that's important because you want to know your community. Who are you speaking with? And if you're unaware, then you need to let that person know. I actually don't know a lot about this community or your culture. I'd like to hear from you, or let me know if I say anything that is incongruent for you or that doesn't make sense. Okay. Or let me learn from you. What do you do about this? Or how do you say this? Okay. Depending on where you're working or what you're doing. Okay. So the first part is this feedback piece. Okay. So here are the areas that you might want to target, are those areas that we were talking about really bringing out in those open-ended questions again, or thinking about improvement areas, risk areas. We're also going to look at impairment or barriers. So functional impairment challenges and barriers. It's using our questions very specifically and listening. Okay. Responsibility. Okay, this is the next section, which is really going back to that person and looking at how they are the person in care. They're facilitating this. It is up to them and what they're ready for. That autonomy piece, that they are the ones to make the changes. You're asking them permission to give interventions. You're not just giving it to them. We don't just educate, right? We ask permission, okay? So you're getting them to make a decision to change or not to change, right? To listen or not listen, right? You're really bringing it back. So again, this is a framework for pulling in all of those skills we just talked about in MI. Okay. So this is where we might look at those goals, the behaviors, okay? Anything that might be facilitators or barriers sometimes, but where's those supports? What are we going to do? Okay. This is where we're bringing that in for change. Okay. We're bringing it back to the person, but it's their responsibility and they're making that choice. And maybe we're offering that as far as that asking for permission. Okay. Advice. This is oftentimes where we're going to get to the next piece, which is menu of options, but it's where we're going to, again, give that piece of, hey, is it okay if I tell you a little bit about blank? Okay. So giving them that stem where, again, follows with that autonomy. Okay. Asking them if they need any information or if that will be helpful in any decision making. Okay. Really giving a little bit of advice, but always prefacing it with that piece of asking permission for the autonomy. So these all link in if you're kind of seeing all of this pulled together. Okay. And that next piece is really the menu of options. Because if you're going to give any type of information, okay, then it's going to be next. Do you mind if I give you a little bit of information about what people typically choose for doing X? Or some of the experiences that I've seen that patients have, or some of the challenges that I've heard about, or some of the things that people find that are really successful for blank, okay? So what type of asking permission and giving a little bit of information, and then go right to what you can do to make that change. What are the exact decisions that they're gonna need to do, okay, to make a change? And so we're gonna look at what are those staged interventions next here, okay? But this is where you give the menu of options. You always want to give people options when you can. So typically we say max of 3 options. Okay. You don't want to go past that. I've seen a lot of people that will go like 5 options or 4 options. Most people kind of stay at that 2 to 3 and you're good. Okay. Because we can actually end up confusing people, and we can even after 3 go, wait, what did you say first? I've had that in experience. Someone's explaining something to me very well, but by the 3rd, I forgot almost what the first was, okay? So it's important to consider that. What are your go-to menu of options? So these would be specific interventions or things that they're gonna do, or action plans, okay? So that's where this is going to be. So you wanna give them maybe 2, 3 max, okay? But it gives them that option. And again, you're asking them to take another step in. I just asked them to take a step in by asking permission so they listen and hear and make a decision on something. Now I'm asking them to take another step in closer and asking them to make a decision on this. So I'm not just going to say, oh, we're going to provide you with, 3 visits of this type of counseling, or we're going to provide you with this medication and that's it. I'm going to give them an option related to that. okay? And maybe it's only the options that are clinically relevant or are evidence-based or are healthy options, right? And, you know, maybe I'm going to give them options that are that's that directive piece and that purposeful piece, okay? We don't give options that are related to just go back and use, okay? That can actually be very flippant, even though sometimes I've heard people say, well, couldn't that be something that I'm supporting, that their resistance and I'm trying to roll with it? We want to give them that other piece. We always want them leaving, seeing that other option. And maybe it's just thinking about it or coming back to ask questions or listening, okay? It may be that has a greater value than just saying,
There you go.
oh, something just happened. That has a greater value than just saying, or just keep using, okay? So remember that that's not an option for motivational interviewing and applying this here, okay? Anybody have questions on that? Just because I heard that mic and want to check in. I don't see any questions, okay. So empathy, and then next obviously would line in is self-efficacy. So again, you kind of see how all of this is pulling in, all of MI, the skills, the framework, it's all very repetitive of these core values, okay? So in it, you also want to recognize every time you're having a conversation, how am I going to be expressing that empathy with them? What am I doing inherently? Can I do a quick body scan or review of myself while I'm actually talking with a person? Okay. What am I doing even just to make sure that the environment is safe? Empathy can be as simple as saying, you know, let's move into this room, okay, and not talking in a hallway. Okay. So trying to do something, whether it be simple as far as an empathy or a nonverbal reflection or something a little bit more deeper, okay? But ensuring that you have empathy built into your conversation is important as a structure every time, okay? Also, obviously, recognizing the value of self-efficacy, okay? We all know it can't be disputed, okay? It's pretty much now done, okay? So we all have to really be focusing in on what am I doing as far as that statement? How am I bringing that patient to that section? How am I illustrating that? How am I helping to boost them up and show them that it's there? Did I hear it at all from my patient? And if I didn't, maybe I need to ask that, because maybe that's a challenge. So I'm either going to give them what I see, as we talked about earlier, as a way to talk about self-efficacy, is give them what you recognize in them as that strength, as that power, as those motivators, or their ability to do that. But maybe I ask them about what I recognize is that I'm not seeing it. I didn't hear it. And so maybe I say that blankly. Okay. And I ask them about that purposely. I haven't heard you say anything about your strengths to be able to make that change, or your ability to see yourself as being able to do this change, right? And I'd be more specific. I'm saying this change to encompass all elements of change, but I'd be very specific about what I'm talking about with a patient. And I would ask them that. I want to hear from them. Do they think that because of their experiences, right? Their life experiences, the community that they live in, their environment, do they see that they can't get out of that? Or that's the only option for them? So I want to hear about the reasons why. The more I know, the more I can help with reducing those barriers or figuring out another way to work around those. The more I can figure out that strength that they have, even if it's their ability to be able to identify all this around them. They're critically thinking all the time then, okay? So always remember that you want to do that and foster optimism as much as possible within those moments, okay? Okay. So as we're moving forward with in MI, there's a lot here about building these base skills and really thinking purposely in our communications and conversations with our patients. Another skill is using assessment. An assessment is a tool that is used obviously for something more kind of larger and therapeutic values and longer assessments. You can also have more biomarker kind of assessments and medical tools related to it. Here in MI, what we're looking for in assessing is really we're looking for a few different things. The first thing we always want to look at is importance. And then the next ones we look at is confidence or readiness often. So you'll hear those types of kind of questions come up. And it's really a quick and easy assessment. Some folks have actual posters on walls or a little card. And I know some of the work tools that were sent out to you have that with a little scaling card of 1 to 10. And this piece of assessment of just using a simple scaling from 1 to 10 is implemented in a lot of evidence-based therapeutic techniques and interventions, from brief actions planning to the 5 A's to things like SBIRT. They all involve this aspect. And it's really important. Okay, so it all stems from the MI research related to it. So I want you to think about whether or not you do any of these types of assessments. Does anybody do any type of 1 to 10 scaling on a quick, easy kind of conversation with patients? And if you do, if you can put in the chat box, what do you do that on? Is it on importance? Is it on confidence? Is it on readiness? Is it on something else? Okay, maybe their value of the visit with you. Maybe you do certain types of scaling that you have, but it's great to hear from others related to what you do. I want to really emphasize this piece in MI that we teach is first to look at what we call conviction, which is importance. It's another word for importance. In the literature, you'll see it all saying conviction. I wish we could cut that out because it's such a high literacy. It really is just importance. So it is what is important. So it's the general practice rule. When importance is low, it needs to be addressed first. Okay. So if you think about it, it makes sense, right? So if someone's working on something and they don't think it's important or don't know why it's important, then they're not going to put the time to actually work on it. They'll put the time to work on other things. Okay. So you'll actually waste time because they don't see it as important. So they're not going to go and do it. Okay. So the other side of it is also interesting because if they really believe it's important and they have high conviction or high importance about something, but they have low confidence, then they really feel stuck too. And so then you're going to really target your interventions toward confidence building. Okay. And that's where you're going to go with all of your conversations. But this is a good place to kind of set the stage with patients and individuals in the community or people you're having conversations with. And there's a lot of MI that we do as far as workplace motivation and using MI to actually have conversations with colleagues and in plans and action plans within employees, and then even within families. And so this is actually a tool that we use in all of those arenas as well. So consider like, hey, how important is this to you? When you're talking about this to me, or when I talk about this, I want to check in, how important is it to you on a 1 to 10 scale, okay, related to making this change, or doing this, or staying here, or attending to this, or whatever it is, be specific. And then give them what 1 in 10 means, right? So, 10 is what? Okay. And then see where they lay. Where are they going? Where are they reporting on that? Okay. So again, we really want to target and target correctly. I've had many conversations with patients in care, and about the 3rd visit, if I didn't ask this importance question first, I've missed it. I've gotten stuck with the patient. I've had many conversations. They keep going. They tell me all about the things they're trying to do. Okay. And they'll give me examples. They'll repeat back what the other providers have told me. They'll say, oh, this medical provider, my primary care wants me to lose weight, and they've been telling me XYZ. They know everything. Okay. And then by the 3rd visit, I realized I never asked them the importance question. I'll ask them, and it's a game changer. I've had patients will say, oh, I don't know why it's important. I just know they tell me to do it. So inherently, if it's not important, it's going to be on the back burner to them. So it gives you a place to really focus your interventions on. Okay. And then of course, a lot of people already use the confidence piece a lot and the confidence questions and scaling, but really make sure that you take down these. If you're going to do scaling, do importance first. You can do readiness, you can do confidence, and you can do the other scaling as well, but always take that. That's going to help focus for you the next level of interventions, right? Do I need to do interventions related to importance and why and linking those values right away? Or do they already know that? And I'm really here to boost that confidence because they have so many roadblocks and barriers that I need to put my time into that. If I put time into another area, and then I'm wasting my time and theirs, okay? So there's a reason why we do it, and there's a reason why we want to do it really early on, okay? So just remember too, when you get that information, you want to go a little bit deeper. You want to use those MI skills to gain a little bit more insight, right? So you want to ask them, wow, why was it a 4? Okay, tell me what would make it a 2 or what would make it a 6, right? Go higher and lower. Okay, so you could say something like, geez, on a scale of, 0 to 10, how important is it for you, or how convinced are you, whatever words you like or feel are congruent for your community, that it's important to monitor your blood sugars every day, right? I want to add those pieces in there. Okay, 0 is like not at all, and 10 is, yeah, I need to do it every day. I'm convinced I got to do it, right? And then if they say something like, it's a 4, okay, you could say, what makes it 4 and not a 0? You're going to get that insightful piece. You're going to get their values right then. Do you see how if you ask this question very early on, you're already getting to the targets you want to go to in MI. You're already bringing that out to elicit where you want to go next to change. Okay. Why isn't it a 6? What would have to happen to make it a 10? So if I start this conversation right here, I'm already building my intervention. I'm already learning what's important for this patient, what their values are, what they see themselves, their self-efficacy, all from this one question. So that's why it's important to put it up first, although oftentimes we don't always do that. We are following the patient and other types of conversation that are going, but that's where you want to learn where your comfort level is and how you want to structure your conversations. Consider this as something that's very important though. Okay. You would do the same thing with confidence. Okay. The same type of scaling again. Okay. So you're scaling with this kind of 0 to 10. Sometimes people do 1 to 10. It's really going to be up to you and what maybe you have as far as posters or rulers that you might want to use if you have a visual tool in mind, but always do the exploring. Okay. Okay. I'm going to stop here. And what I'd like to do is show a little bit of a video. Okay. Of a person who's actually providing some care to a patient. And I want you to recognize in here, I want you to kind of listen for certain things. I want you to listen for asking for permission, right? Scaling. I want you to kind of hear, oh, did they do anything related to feedback? Are they doing anything related to affirmations? What are their nonverbals? I want you to listen and watch and recognize, what do you see here? Okay. So I'm going to go ahead and pull the video.
And Dr. Manson, you're muted now.
Thank you. Let me just switch over the video. Thanks. What, you all don't hear that video? Sorry, a little joke. And then place in the chat box if you are unable to hear it, okay? And there might be some video lag.
How are you feeling today?
I'm okay. How are you?
I'm good, thank you. Let's talk about your medication. Do you have them with you?
Oh, I sure did.
Good. HCTZ, 25 milligrams. That's right too. Have you been taking all of these medications like how it says on the labels?
No.
Why not?
Well, I take 2 of the medications, but the other ones make me feel dizzy.
Oh, okay. Well, that's just part of the side effects. In order for you to stay healthy, you have to take all of these medications.
I'm not going to take any medicine that makes me all dizzy.
I understand, but it's very important to take these medications, as Dr. Jones said.
Well, every time I call the clinic to tell them about my headaches, no one answers the phone, so I just give up.
Okay. That makes sense, but as long as you follow the directions on the labels, it should be okay.
I'm not going to take any medicine that makes me dizzy.
Did you talk to Dr. Jones about this?
Well, every time I call, nobody's answering the phone.
Okay, so I think that's probably enough for everybody to understand and kind of get that message. Okay, so what are some of the things that you all saw on the video? Was anything that followed MI techniques? Were there anything that were counter to that? Go ahead and either shout it out or put it into the chat box. That was uncomfortable, yeah. Something? Yeah.
Yeah, I was just gonna say the why question, the kind of accusing question was not good.
Yeah, it's almost the writing reflex right there. Okay. You got to take it. Has anybody said this actually looks like something that would occur? Anybody had that? I've seen it. Okay. And I'm not ashamed to even say that there's been times where I've had the writing reflex. And I hope that I've caught it every time. Okay. But it happens. Also, did you notice the kind of the face, both from the patient and then also for the person that's there, the healthcare professional, right? And you're right. You notice that he's not hearing. And then it also seems very harsh and empathetic, right? Like it does not seem comfortable. So let's see it now with more of the pieces and listen with more of that pieces of MI in mind and see if you can catch any of them going on that way. I'm going to hit play and then I'm going to switch over the video. It just takes a moment.
Morning, Cherise. How are you today?
Fine, how are you?
I'm good, thank you. So Dr. Jones asked me to do something called MedRed, which is when we go over your medications. Would that be okay with you?
Sure.
Okay. Did you bring your medications?
Yes, I did.
Oh, that's very good. Oh, a lot of them. That's a lot to keep track of. Okay, let's go over this one first. Can you tell me what this medicine is called?
Metformin.
Metformin, that's right. Now, did you and Dr. Jones get a chance to talk about what this medicine is for?
Oh, yes, my metformin is to lower my blood sugars.
That's exactly right. Now, can you tell me from this label how many milligrams each pill has?
500 milligrams.
500. And then can you keep reading and let me know how you're supposed to take this medicine?
2 pills twice a day.
Mhm.
I've been taking 1 pill in the morning and 1 pill in the evening. I've only been taking 2 pills, and this says 2 pills twice a day.
Okay, well, that's okay. It's completely understandable. It happens to a lot of patients. These labels can be really confusing. And so, but it is very important that we keep note of how you've been taking this medicine. Would that be okay with you if I wrote it down for Dr. Jones?
Yes.
Okay. Okay, and so just so we're on the same page, can you tell me again how you're supposed to take this medicine?
I'm supposed to take 2 in the morning and 2 in the evening instead of 1 in the morning and 1 in the evening.
Okay, and how many milligrams will you be taking each day?
I will be taking now 2,000 milligrams.
Exactly right. Exactly right. Okay. Can you tell me from this label, that's this part of the label, how many refills you have left?
I have 3 refills.
Okay. And do you think you need one right now?
Yes.
Okay. I'll let Dr. Jones know as well. But you can also go to the pharmacy and fill out the prescription yourself. Do you have any questions about that?
No.
Okay. Well, do you want to ask me anything about metformin?
No, I think you answered all my questions.
Okay, great. Which one do you want to go over next? How this one?
That
This looks-
bonanza
Yeah,
stuff.
this one's really confusing. Let's do this one next. Okay, what is this medicine called?
Bonanza. I can't
Yeah,
pronounce
it's
it.
really hard to say. A lot of patients, I have trouble saying it sometimes. It's actually pronounced benazepril.
Bonanza.
Okay, so benazepril. Do you know what benazepril is for?
It's for my high blood pressure.
That's right. That's right. And can you tell me how many milligrams are in each pill of benazepril?
Okay, so definitely different here, right? So I'm seeing that did the affirmation, that looks like communication now, right? So very different experience. Put down in the chat box or feel free to turn on your microphone and camera. What did you recognize in that video? What did you see? And did you see anything where he could have done even better? Because we're never perfect, right? What did you recognize in there? So we're on the same page, right? Some specific wording used.
Eye contact. I mean, he was really looking her in the eye, talking to her.
Love it. Yeah, very different. I also noticed the smile. Did anybody else see that? Like he was purposeful. He was sitting at his computer for a second, and then he was like, looked up, smiled, and made sure to show that to her, right? Okay. Oh, other people, Kim, nonverbal, smiling. Yep, Mary, more comforting, understanding of the patient, more of a collaborative approach. That's right. And did you notice the specific MI skills? Open-ended questions, right? Empathy, summarizing, asking permission. Okay, did I get that right? Okay, making sure to come back. Was there anything you would do different? Not to be critical, but right, we all can learn after everything, even if we're doing awesome at it. So Patty said, how could he have asked the dose, etc., without sounding like he was quizzing her? Yeah, that's a great one, right? or maybe even give a little bit of information about why we want to ask that. Okay, what's important about it. Ask how you're, yes, like give some instructions about the visit. And this time too, you saw that he tried to set the stage actually. So there was an actual purposeful reason for the conversation too. It wasn't just we're going to have a conversation. It is we're here to do this. Okay. And that's an important piece of the focusing in MI is that we're going to be very specific with it. And we want to get to that because sometimes patients have a lot of goals, a lot of areas, okay, a lot of areas, whether it be of, motivation or concern, okay, or areas to change, but we really want to focus, okay? So we want to really help them to do that focusing as much as we can and set that stage there, okay? He did seem like he wanted to speed things along. Yeah, Samuel. So what would you do if you felt like maybe for some of your populations, that would be uncomfortable, right? Depending on where I am, sometimes in the US, people will like get me and they'll call me out by some of my brought up cultures. So they'll be like, you're a fast talker. You talk with your hands, right? You must be from back east. That's what they tell me, right? You say medical neighborhood, like you say these words, right? But it's because I'll speed talk at times. When I catch myself, I bring it back, but it's from how, I was raised and learned, right? And I replicated my verbal patterns by that. And in other areas, that's actually a sign of disrespect, right? Or people feel uncomfortable or they can't listen as well, or they can't keep up. Okay. It doesn't help with their learning. It's not communicative. So sometimes just kind of normalizing that too and letting them know about how you talk. And so when I am with other individuals from communities or patients, I will let them know that if they don't know me. As I'll say, sometimes I might talk a little bit fast. If I do, throw something at me. Or if I do, let me know. And sometimes I'll slow myself down, right? So maybe do that. Or if there's a time crunch, give that to the person. I know we only have X amount of time today. So if I seem like I'm going a little bit fast with my questions, that's why, but I still want to make sure I answer all the questions you have. Or I still think it's important that we take the time that we need to on some of these areas today. Okay. So this is a great video series to be able to see. There's lots of videos that you can look up. And if you want to implement MI in your own healthcare practices or with your teams, consider really bringing some of these type of videos in and asking everybody to do the same thing. What did you see, right? What would you do differently? Asking them those questions so you can move forward and do that open practice every time. And it's very healthy to do this in large scale community clinics or clinics in general, where you bring together everyone, like during an all staff meeting and show a video and have front desk and medical records, right? And individuals who might be behavioral health providers or medical providers all see different aspects or elements that they're going to shout out. Okay. And then it's interesting just to see what other people pick up on and others don't. Okay. So this is a great way to do that, but I'm hoping that you're seeing that with these specific skills in practice, it is a very different feeling. And also see how you have to be very purposeful with utilizing them too. We can utilize them and still make good conversations and impact, but the whole point of MI is to be more purposeful related to it. Okay, that's that skill building with it. So now let's talk a little bit about that, really refining the skills and making it purposeful with staged interventions. So for me with MI, I still am a believer of the stages of change. And I utilize stages of change whether I'm talking to my kids sometimes or when I'm working with patients. And also with myself when I'm checking in about why I haven't done that thing that I keep having on my planner or my sticky note to do for weeks, months, days, hours, whatever it might be, okay, years. It's really important to just kind of recognize that, because that really gives us an ability to say, okay, then if I want to make a change here, this is what I need to do. It's not just it's going to happen on its own. We need to be purposeful with how we're going to implement these techniques and these interventions so we can move someone. So practice and research has come together and demonstrated that most individuals, they're not ready to commit to a change right away. Okay. In fact, most people who present in primary care for their general medical health needs, only 15% of the time are ready to actually do what you need them to do to get better, which is why some of the concerns we have with healthcare, right? But recognizing where they're at in that stage is really important, because then we can do a different intervention that is more geared toward moving them forward. Okay. And when you do these stage interventions, you have over a 40% likelihood to get them to the next stage within 3 to 6 months. Okay. So that's why we're really going to be looking at these pieces and they're very impactful. So the first stage is that pre-contemplation stage. And this is where, people have that no immediate future plans. And I'm going to go through these really quick because most people have a generalized understanding of these. But you can also read more about these later, okay? Because again, this is just this introductory piece of it. But pre-contemplation, that person where you're going to underestimate the benefits of change, they're going to overestimate the costs and the cons, right? No, can't do that because of X, Y, and Z, okay? During this time, the person usually is hearing more things about the shoulds. They're getting shoulded to death. That's another MI thing we say a lot. Sometimes you'll hear a lot of mental health providers say those things, don't should them. Don't should them to death, okay? So those things are bad and they're unhelpful, right, in those kind of terms. A person also will end up tuning out a lot because they're used to hearing that. They're used to not being brought into the conversation. They're used to being talked at, okay? So they'll often shut down or just kind of like ignore, okay? And sometimes they'll be aggressive because what they say or what they feel or how they feel isn't really being accepted by others because they're pressing that other viewpoint, okay, to change on them, okay? So in this time, there's very specific interventions you want to do, okay? Obviously, establishing rapport and trust is like #1, paramount right now, okay? And that happens pretty quickly, so we really want to make sure our nonverbals are illustrating that, okay? And we really want to raise awareness and concerns for the person. So this is going to be listening to them and asking them some questions. So we learn about why do they want to be doing what they're doing, right? How does it benefit them? And we're going to be listening for those areas that might be areas of concern or change, perhaps, okay? We also are going to be listening for areas of risk. So even if it's not areas of concern or change for them, we're hearing maybe risk. And then at the end, we're going to be bringing that up to the person, okay? So I hear you say these are the things that you really get out of it. At the same time, these are things that are occurring, or these are the things that are really concerning related to the risk of that, okay? So you're really basically just putting it out there, and the ask is for them to listen to you related to that. And the ask would here at that pre-contemplation stage would be to come back and sit and listen, okay? Or read something, or perhaps listen to their friend or family member or something. The ask isn't go into inpatient treatment for 15 months. Okay, unless of course they had to, okay? But at this stage, there won't be that change that comes with that. So here are the interventions that's going to get them to where we want them to be, which is that contemplation stage next, okay? Contemplation stage is where a person's really starting to think about that action. They're not ready yet, and that's really important because people in contemplation and preparation often jump to action, but they're really not there, okay? So they're thinking about it, but they may not really know how to get started. So they might be looking around, okay, and hearing things, but really it's a few months down the line that they're going to go into that, okay? But at this stage, if you recognize someone's in it, they really need that guidance and information. And here's a good time to really talk about pros and cons again with them, okay? And you'll see this person because you're kind of see them maybe that they're kind of sitting on a fence a little bit more, where they can tolerate even a little bit more of you talking about other areas, or you notice them even listening. So if they're in a mandated group even, and you notice that they're listening, that could be often a sign as well, okay? And perhaps before they were giving you the nonverbals that they weren't listening, that they didn't have empathy with the individuals that they're around, okay? So this is that a good period of time where you're targeting your interventions or those menu of options, okay? And what you're going to be giving them is going to be geared toward this. This is the time to give them new information, okay? This is the time to clarify related to the decision is theirs again, okay? Autonomy really reinforcing that. It's also really important to validate if there's a lack of readiness, okay? Because you want them to be ready and prepared. And you might even want to talk to them. I'm a transparent MI, so I do everything with like visuals, and I often will talk about things like, well, today what I use is something called motivational interviewing. It's a form of having a conversation. Sounds kind of big, but basically I use specific techniques that I hope will help our conversation feel better than other conversations you had with others about your health. And then I say to patients a lot of things like transparent again. I say, when I hear you say X, Y, and Z, I'm wondering if on the stages of change, which is where kind of sometimes we see where we are in motivating or motivation toward making a change, I hear and I'm wondering if you're in that contemplation stage where you're kind of sitting on the fence, Or do you see yourself more in preparation where you're actually ready to go toward that direction, but you just need to get a little bit more of resources and support to get there? So I'll be very transparent about it, and I'll ask for clarification with the person in front of me. So I get that reinforcement, and then I go directly where that needs to go. Because if they say, yeah, I'm kind of sitting on the fence, great, I just affirmed it. Okay, I know where we're at, and this is what we're going to do. And these are going to be my interventions. Okay, and again, I'm more transparent related to it, but everybody has their unique approach. Next is preparation. Preparation is where that patient is really actually talking about action, and they're getting things together. They bought books. Maybe they talk to their friend about quitting smoking and they use things to chew on. And then they're like, yeah, so I got some straws. You know, they're making plans and doing different things. They got a flyer on a group or on some sort of treatment. They asked their friend that has diabetes, what do you do? How do you take care of yourself? Okay. They're doing things. It might be small steps, but they're important for that preparation. Okay. This is the time too, where pros start to outweigh the cons. Okay. And that's really important to highlight that as well. And this is the time to really build a lot of confidence. And again, align where their readiness is, because if they jump too soon in this stage, then relapse, okay, is going to occur. And then that can bring them back too far right away. So you really want to actually be very transparent about that in this stage. Let them know that oftentimes people jump into action when they're starting to make these preparations. And you want to have a conversation with them so that they feel prepared and ready. And so if they hit a barrier or have any concerns, that they know which direction to choose, right? And so you're really going to want to talk to them about that and be very transparent about it, okay? And maybe even say, what do you think about, I know you want to do that today. What do you think about starting it on Friday instead, after you do a little bit of this, or after you find out about this, or after blank, blank, blank? Or what would you do if this occurred, right? Try to get out that to find out what are those areas you want to do. So again, your interventions in this stage are about problem solving those obstacles, identifying support, okay? Doing the skill building for the behavior change, and really emphasizing small steps, and maybe even writing it out for the best preparation. This is a stage that if you know a patient might be jumping into that action, you could ask them even, would you mind giving me a call if you do start it, so that I know? Okay, I've had patients, and one of my good colleagues, we did some MI certifications together with MINT and Institute of Healthcare Communication, well, about 15 or 20 years ago. And the primary care provider with me was like, you know, I use this all the time, and I ask them to call me back. And to this day, she always has a story she pulls out that she says, it was about 5 years later where a patient who moved to a different area, was literally living 3 to 4 hours away, came back and like called her, left her a message, and made an appointment with her because she had told her to let her know when she was ready to make that change, and she was finally ready. So she was in this stage of going back and forth from contemplation and preparation a lot. She finally was there, so she came back. She was like, I'm not your provider. She was like, but I'll help you. But it demonstrated how impactful that was. The patient told her, nobody had ever told me that before. Nobody gave me permission to think about this and do it, and to recognize where I'm ready and actually be ready for it. And so I am. And so I came back to you because I felt like you heard me on that. So it's just an interesting piece that she consistently will give in her talks about the directions. So action is that stage that we all want everybody to be in, okay? And obviously we probably know where people are in action, right? They're doing it, okay? They're moving toward different areas, but they have a lot of needs too, right? If they're still remaining in the same community, family, friend groups, those things need to change with it, and change is hard. It might be the only thing constant, but it's actually a barrier too, okay? So we really want to be very, transparent about that, and have discussions related to that, really talk about ways that they can help have conversations with their other friends or family members, ways to maybe build and bridge new environments as well. Okay, how can they balance that? Okay, so we focus a lot of social support and structure here. We also might have to deal with a lot of feelings of loss too, because of the change, but always concentrating on self-efficacy and that SMART goal setting here as well. Okay, so you see here's where we're focusing all of these very specific stage interventions. When you do this at this stage, you're more likely to get them to maintenance stage, okay, and be able to stay there. This is where the person recognizes that it's inherently needed to continue to monitor for themselves and keep themselves here. They're a little bit more confidence level, which also brings some risk, okay? Meaning this is the stage where also a lot of relapse or lapse occurs, is in maintenance, okay? Although it can occur earlier, this is where it happens the most as far as being very risky for people, because they have accomplished so much and then they feel like they go back. So it's really important to be transparent about this stage here and really work on those interventions related to it, okay? So the interventions are really related to planning, reinforcing those internal rewards, really emphasizing their new ways that they can use their knowledge and grow in their skills. Some people don't believe in identification, which is another stage of change. In some kind of therapeutic modalities, maintenance is where it stays. Others do believe in it. That is where a person just is what they are. They're a non-smoker, okay? They never go back, right? Some folks are able to do that. Some folks aren't. When you look at what we call, research related to it, we typically say they've been in it for about 2 years or so. People also will say that's maintenance. So it's really up to you and your belief system on it, but really it's the same pieces as far as your interventions you would do at the maintenance stage, okay? And really making sure that you're reinforcing it. So these little pieces as far as interventions, they're already in kind of cue cards that you have. I had one last activity to do with you all today and want to kind of check in with you, but I want to first I think we've got about 10 more minutes. Am I right on a time check? Okay. Oh yeah, Kim. Okay. So I want you all to think about, I know I went through those fairly quickly as far as the stages of change and the specific interventions, but just know that you are going to have actually cue cards and little pieces that give you that. And obviously those interventions in and of itself could be a webinar just to kind of concentrate on what are those stage pieces. But when you first learn about MI, I feel like it's really important to bring them together. So when you sit with patients, you can kind of see what's their stage of change. So reflect on that. Maybe even thinking about previous patients that you've seen and thinking, where have they been? And what was the interventions that I had? Were any of them incongruent? And now what would be the skills I'd purposely use to show and actually demonstrate something different, okay? And that's where you bridge those MI techniques. I'm gonna show one brief video. It's only about a minute long. Sorry, it took me too long to do that. And I'm gonna go ahead and push play and I'll shoot over to the video in just a second here.
Guess you're gonna bawl me out today.
No, Mrs. Johnson.
It doesn't matter what I do. I'm good for a few days and then something happens.
What?
I go off and I'm right back where I started. I just want to forget the whole thing.
You can't forget diabetes, Mrs. Johnson. It won't forget you.
I do forget. I want to forget. I forget to do my finger sticks.
Mm-hmm.
I forget I'm not supposed to eat what my kids eat. I forget and eat whatever they're eating, like cookies.
I know. It's difficult.
It's more than difficult. It's impossible. There's something I don't get. Look at my mother. She's 75. She's fine. She don't do none of those things. How do you explain that? She's diabetic too.
I can't, other than to say she's not you. I need to know a lot more about her history. And even then, I think it's important to keep in mind that everyone is different, even within the same family.
I don't think you understand. I'm just not going to do this.
Okay, so obviously, anything that people recognize there? Any skills that you saw that maybe you heard from the clinician there doing? Anything that you said, oh, they were doing that?
Pointing out she's her own individual.
Yeah. Okay. I do think the clinician was really trying to demonstrate some empathy, right, with their nonverbals in some way, leaning in, trying to be focused on the person. But there's also a lot of areas for improvement. Okay. I show this video in specific because this person really is demonstrating. This is actually a real intervention and interaction that occurred. It was videotaped as far as a primary care interaction and then redone with patient actors. Okay. So this actually occurred in primary care. Okay. So when we look at this, there's also a lot of ways that we can use MI very purposely. She gave us some areas about value. Did anybody hear values really quickly? Anybody pick up on what would be a value that she said? What did she say that was important in her life? Anybody hear it? I know it's toward the end. It was like, we're trying to escape. I don't know. So some of the values, and it's very quick. When you're in a moment, it's hard to sometimes pick up on it. You got it, Patty, right? Eating with her kids, her family. There was a lot of reference with that, which demonstrates to me there's a lot of time there. There's a lot of value there, right? So I'd want to really illustrate that and go there. There wasn't also any asking permission to give any, information or advice, which I think was not, given a lot of, respect back, right? So she ended up kind of forcefully giving her viewpoint to her because that wasn't occurring. I don't feel like there was a lot of giving the patient the respect of her challenges and really going into that with her. There wasn't even a lot of discussion of the challenges. She was actually trying to force her to give her the challenges. And there was nothing from that clinician that was really acknowledging them other than, yeah, it's hard. Well, diabetes isn't going to forget you, right? Which you could see as maybe a way to motivate them, but also it was a way to put them down in some ways too, in the experience. So I want you to oh yeah, Kim, do you want to say something?
I just had a quick question. I know there was a lot of resistance that appeared by the patient, and just a few minutes ago, you talked about if we switch the resistance and use that, would that be a way to potentially guide her? So, for example, I could see that you're very adamant about this. What could you do differently? So anyway, I was just curious if you would use that resistance to switch and how you would do that.
Yeah. And I think the clinician had said something like, I can see and I think there was a way that she was trying to start there, but that's definitely something that is a great tool to use, is basically go with what you see and try to have the patient answer a little bit more about their story, about what's going on with them. But then don't forget to stay there. Don't try to go somewhere else with it if the patient's not ready yet, not unless you're aligning their values with it, okay? So if you go straight toward giving them advice, but you didn't ask permission, you didn't align the values, you're gonna lose them and they're gonna keep putting up the resistance. So you've got to roll with that and keep within that area. So when she gives the experience and the challenges, you want to talk about those challenges, not deflect on it and go somewhere else. Don't problem solve immediately. That's that key error that would happen in the very beginning of that conversation too, okay? And we might want to get at what's important for her and know, is this really important to do? And what does she know about the importance? Because I also hear her saying she doesn't understand why it's important. She was saying that. I see other people that have it and it doesn't seem important for them. So why is it important for me? She actually asked a question like that, and that importance wasn't even answered, okay? So those are the things that we really want to get to and really utilize these skills to apply them purposely. Going over videos and just having these conversations can be very helpful. I want to just stop here for a moment and ask everyone, I know we went through a lot and learning some of the basics of MI, it can be hour long, right? People go through workshops for weeks to do this. But just thinking about this in this couple hours long, does anybody have specific questions about motivational interviewing or some of these skills and how to apply that? Or questions that come up about anything related to these skills for you in care? I'm not seeing any questions coming up. So I hope that everybody was able to kind of get a refresher from the MI skills for yourself if you've been in MI before, and also some ways to be able to really emphasize or actually improve upon your skills to get to that specificity area. Okay. For those of you who are new to MI, I hope this was a good introduction to learn a little bit about the specific skills, the spirit of MI, a little bit about staging and stages of change. Okay, and how you can look at that and practicing with the videos. I hope you can start to see, oh, I can see it. I can see it now. Okay. Ultimately, I want everybody to walk away with the baseline of understanding what those skills are for MI, but also how you need to get to the purposeful level of implementation. Any implementation is a good start. Okay. And then as you progress, start to really consider being more purposeful with it. Okay. I know that there's some kind of whether is it like a webinar or a different type of link that they have to get to, Kim? Or are you sending that out later for their CE and other things? Oh, there it is. Jenny just posted it. I know there's a survey to answer at the end here. So that's also going to help you if you need CE for you to receive that as well. So go ahead and click on that so you can learn a little bit more about that. And just so you know, everybody gets hours for CE for completing this if you're interested. Okay. And just to reinforce for everybody that a few things is that within complementary evidence-based intervention structures, with MI, it's inherently and built into SBIRT. That's what SBIRT is based off of. Okay. The 5 A's, you'll also see that within MI too. And the brief action planning protocols, BAPs. I don't know how many people are using any of these pieces as well, but you'll start to see MI within all of those as well. Okay. If anybody is interested in more resources, I have literally annotated bibliographies as a trainer that I can give on MI and all aspects, whether it be for empathy in healthcare in specific, whether it be about helping people to motivate toward behavior changes in healthcare or substance use. I have a lot of those. I'm more than happy to give even more resources for folks that need it. In the end, you also are going to have some resources that you can use as workplace cards, and we'll probably send some more out to you a little bit later. But I want to thank you all for this time, and I hope it was something that's helpful for you all to have experience today with your time. I appreciate you all giving me these couple hours. So thank you.
Thank you for the wonderful presentation, Dr. Manson. We appreciate your time today. We know 2 hours was a long time to be present, but thank you for your attention. And please don't hesitate to reach out to us if you have questions, if you'd like more resources, and we look forward to seeing you.